Dr. Mark A. Bell with the final section, final module in our cancer screening and primary care series. And now we're going to focus a little bit on cancer screening in Ireland in comparison with other countries, and also applying what we know to breast cancer screening, kind of digging a little deeper into one cancer and looking at some of the trade-offs that we might make in terms of when we start, when we stop, the impact of overdiagnosis. So the current programs in Ireland, which has centrally organized screening, are for the Breast Check program, which is mammography every 2 years for women 50 to 64, currently in the process of increasing to 69. Cervical Check, which is a pap smear every 3 years for women age 25 to 60, and then reflex to HPV testing if abnormal. And Bowel Screen, which is beginning with men and women age 60 to 69 years doing a FIT test every 2 years. So how does that compare with other countries? We can see Ireland is pretty much in the middle of the pack in terms of cervical cancer. So these are other countries, US at the top, and then most of the other wealthiest OECD countries showing their programs. Some start a bit earlier, some go a bit later, but Ireland's kind of in the middle of the pack. Similarly with breast cancer screening, Ireland is very typical of other mostly European and well-developed economies. The exception, if you look at this graph, becomes pretty clear. Japan and Iceland both recommend starting at 40. US guidelines recommend either starting at 40 or beginning shared decision-making at age 40 and then continuing to age 75. The American College of Radiology is the only guideline that continues to recommend only annual screening rather than biennial or every 2-year screening, which most, in fact, all other countries recommend as their standard, other than the UK, which is every 3 years. So again, Ireland kind of in the middle of the pack. If we look at the comparison with other developed economies for bowel screening, you see that Ireland is similar to Iceland, UK, and Finland, and New Zealand in that they recommend starting at age 60. On the other hand, most countries typically start around age 50 and continue to 70 or 75. So a bit shorter interval, but the capacity is being developed for colonoscopy in Ireland, and they probably will expand that over time as the capacity is built. So let's look a little more into breast cancer screening. So some key questions are, does self-breast exam provide a net benefit? Does mammography reduce mortality, and if so, for whom and how much? What are the potential harms, and is there overdiagnosis? So breast self-exam has traditionally been recommended by many groups, but when it's been studied, it has not been shown to be helpful. 2 large population-based studies were done in China and Russia, 2 countries where mammography is not used as a screening test. And basically in the Shanghai study, they trained over 250,000 women in over 500 factories, and they randomized them by a cluster design to either teaching breast self-exam plus providing reminders or usual care. They did a good job. They repeated the training sessions regularly, 10-year follow-up. There was no difference in cancers detected or breast cancer mortality, but more biopsies in the self-exam group, so more harm than good. Similarly, in St. Petersburg, higher incidence of cancer, no difference in mortality, twice as many biopsies. So again, no clear benefit, but more potential harms. This is looking at randomized trial data by age group for mammography compared to no mammography. What you see is that the relative risk reduction is not quite statistically significant in the women in their 40s at the top of the diagram. You can see it's 0.88. Confidence interval is 0.73 to 1.003. 50 to 59, there is a statistically and I would say clinically significant reduction in mortality of 14%. 60 to 69, there's even a larger reduction, 33%. So that's the group that experiences the greatest potential benefit, is 60 to 69. And then 70, 74, 20% relative risk reduction, not statistically significant, but that's primarily due to relatively small numbers. Not many women that age group have been studied in breast cancer screening trials, and no women over age 75 have been studied. So I think the takeaway is that the greatest benefit is for women 50 to 69, and that's reflected in the cancer screening programs for most countries. Now you could make the argument, what about reducing morbidity or the number of advanced cancers by starting earlier? Maybe we could see a benefit in terms of not having to treat as aggressively if we can begin screening at an earlier age. So this looks at women who had screening in their 40s versus after 50 years, and what we see is absolutely no difference in advanced cancers in the younger women, but a significant reduction in the older women. So again, supports roughly age 50 as a reasonable starting point for the onset of mammographic breast cancer screening. What about all-cause mortality? Well, if you look at this, there's actually no significant all-cause mortality reduction. But if you look at the point estimates for each of the trials, they actually are all but one to the left of one, which supports reduced all-cause mortality. And if you look at that absolute reduction of 0.01 in the relative risk, that's not quite statistically significant, but almost, that corresponds closely to the absolute risk reduction in terms of disease-specific mortality. So again, disease-specific, all-cause are consistent, and that makes at least me comfortable that yes, there probably is an all-cause mortality reduction. We just don't have large enough studies yet to be able to completely prove that. So what about overdiagnosis? Is there overdiagnosis with breast cancer screening? Two researchers, Drs. Bleier and Welch, published an article in the New England Journal where they used data from a cancer registry in the U.S., and they looked at trends in the incidence of early versus late-stage breast cancer. They classified early as localized disease, or CA in situ, so carcinoma, ductal carcinoma in situ. Late stage was regional spread or metastatic spread. We talked about earlier, we would expect to see increasing incidence of early disease, but after a while, a compensatory drop in late-stage disease. Here's the data. The top bar graph shows the uptake of mammography among women in their 40s and older in the U.S. It began in mid-1980s. By 2000, there was an excellent uptake, over 70% in the U.S. Corresponding with that, we saw a large increase in the incidence of early-stage cancers, which, as we said, is to be expected when you start screening. But we don't see that compensatory drop to the same extent. When they did the math and tried to adjust for variables like hormone use of hormone replacement, other factors, they saw a decrease in late-stage disease, but it wasn't nearly as large as the increase in early-stage disease. So a lot of those early-stage cancers that were being detected and treated aggressively were overdiagnosed. In younger women who younger than age 40, who were not subjected to mammography typically, certainly not for screening, there was no such increase in early-stage disease. Again, more evidence that it was the mammography leading to an increased risk of early-stage disease. So for women 40 to 49, let's kind of tote up the benefits and harms. We saw that there was less relative risk reduction than in older women. The harms are also potentially greater. Breast tissue is more radiosensitive. There are more biopsies and cancers per cancer detected, and more false alarms and cancer scares. So if we look at the table, it shows that if you were to start screening as age 50, that's the first column, versus age 40, the second column, you have one fewer breast cancer death for 1,000 women screened over their lifetime. So one woman out of 1,000 has a major important benefit. She lives typically 30 years longer. Life years gained is 30. But now we get into the harms. False positives, over 500 if you start in the 40s instead of 50s. 58 more breast biopsies, plus an estimate of 2 more overdiagnosed breast cancers if you start in your 40s than in your 50s. So there's 2 women who are going through all of the trauma of treatment without any likelihood of benefiting from that. Another useful statistic to remember when you're talking to your patients, if there's no screening, you have a 3% risk of breast cancer death on average. If you screen 50 to 75, it goes down to 2.3%. If you screen from 40 to 75, so you start even earlier, it only goes down to 2.2%. So that's a very tiny difference in mortality rates with the more aggressive screening. What about every 2 years versus every year? Again, the American College of Radiology and the American Cancer Society, to a smaller extent, recommend annual screening. What's the impact? There are 2 fewer breast cancer deaths, but you have 9 more overdiagnosed tumors, which is a major harm. Nearly 100 unnecessary breast biopsies. In addition, false positives, you have over 1,400 more false positives, and the life years gained is 40 by doing that. So these women are gaining about 20 years each. So those 2 women have a significant benefit, but 9 women are pretty significantly harmed, and dozens and hundreds of other women have more minor harm. So most countries feel the balance of benefit and harm lies with biennial screening rather than annual screening. So this is what makes cancer screening hard, and the decisions around it so complicated and sometimes controversial. The minor harms of screening and the costs of the test affect everyone who participates. There are more serious harms related to biopsies and evaluations and surgeries that affect a smaller number, most of whom don't benefit. In particular, overdiagnosis is increasingly understood as being an important potential harm. If we look at the example of mammography, if we screen 1,000 women beginning at 40 versus 50, we prevent 1 premature death, and that woman lives 30 extra years. On the other hand, half of the women have a false alarm, 50 more have a breast biopsy during their 40s, 2 to 3 women are overdiagnosed and treated unnecessarily, and so we're in a situation where I think 2 well-informed, intelligent women might make different decisions about screening in their 40s based on their values regarding harms and benefits. So that's why, at least in the US and in some other settings, shared decision-making is the norm. And in general, whenever we embark on cancer screening, there should be some element of shared decision-making, and it should never be forced on patients. So here are the answers to our quiz. You've probably been following along and hopefully have seen these. So for which cancers is free screening offered in Ireland? Cervix, breast, and bowel. How likely is it that an average risk woman dies of breast cancer? We just learned that that's 3% or 1 in 33. And that's interesting because most women in surveys feel like their risk of dying of breast cancer is much higher. If Mary gets mammograms every year from 50 to 69 while her sister doesn't, how much less likely is she to die of breast cancer? About 30%. 3% down to 2.3%. Now that's not 100%, which is the false belief held by many patients. So I think having a realistic appreciation for what cancer screening can do, but also a realistic appreciation for what it can't and what the potential harms are, is important as we educate our patients. Finally, in summary, cancer screening is an important part of GP practice. We have to discuss recommendations with patients, help them understand true positive and false positive results, and make sure they get the proper follow-up. Screening should only be pursued for a cancer or other disease when it decreases mortality with acceptable harms, burdens, and costs. Overdiagnosis, which means detecting a cancer by screening that never would have caused harm, never would have caused symptoms, is an important and increasingly recognized harm of cancer screening. The Irish National Screening Program recommends screening, as we've discussed, for breast, cervical, and bowel cancer, and it's a centralized program with invitations to screen mailed by the National Health Service. Thanks for paying attention to this series of lectures. I hope you found them helpful.